At Northwell, we have over 20 hospitals within our health system, and there are varying degrees of resources for diabetes care at the different hospitals. The Division of Endocrinology has helped establish a health system-wide diabetes task force so that we can ensure high-quality diabetes care even at the hospitals that don't have, for example, endocrinologists. What we do on the task force is we get representatives from all of the hospitals, and we can use resources from one hospital to generate guidelines or to pilot new initiatives, and then we can disseminate those to the other hospitals.
The endocrinology team values collaboration with the various services throughout the hospital. For example, endocrinology has worked very closely with anesthesiology at Northwell Health to come up with protocols to optimize management surrounding SGLT2 inhibitors, GLP-1 receptor agonists, perioperative management. Furthermore, collaborating with the emergency department in order to make sure that the optimal diabetes care is occurring for patients admitted. Additionally, our population comes from a very diverse community. Queens County, which serves many of our hospitals, is very ethnically diverse. We have many non-English speakers, many uninsured patients, and so we do have to devote a lot of resources to making sure we can give the best care to this challenging patient population.
The role of the inpatient diabetes team is to manage their diabetes and their hyperglycemia in an efficient and safe way. We need to have a good assessment of our patients. So when we go and see our patients for the first time, we want to assess not just the history of diabetes, their complications or comorbidities, but we also want to assess their ability to self-manage their diabetes. We also want to know if they are able to get their medications, if they have insurance, if they have any social or family support that is helping them in the outpatient side. Our team also follows patients that have transplants. The immunotherapy that the patients receive can cause steroid-induced hyperglycemia in patients that never have diabetes, but also it can worsen the diabetes on patients that already have diabetes and have a transplant. And that's why the communication with the transplant teams are very important.
With a third of hospital admissions being with patients with diabetes, and only one full-time certified diabetes care and education specialist at LIJ, the need for increased resources was identified. So in 2010, LIJ developed and implemented Diabetes Champion program so nurses know what to teach, and it focuses on survival skills for our patients. Then on every unit, there is a toolbox that contains a demo insulin pen, injection pads, pen needles to give further resources for the nurses to be able to teach. And this helps them empower them and take ownership of that education. In addition, LIJ has embedded diabetes education in their onboarding.
In late 2023, we launched our food insecurity pilot program here at LIJ. We wanted to address a broader need coming from our community. We found that a lot of our patients were screening positive for food insecurity, so we came together as an interdisciplinary team to really come and engage our patients for this health-related social need. The transition period from the hospital to home is understandably a very vulnerable phase to be in for a patient. So we are able to provide food pantries, recommendations, as well as community-based organizations, and we are able to provide a grocery bag on discharge to home. We obviously want to reduce their readmission rates, ensure that they aren't facing diabetes-associated complications, and ensuring that they have good glucose control once they're at home.
So it really is a team approach to safely transition a patient with diabetes from the hospital to home. I collaborate with the primary teams, I collaborate with the nurses, especially on an education basis, handing off what needs to continue to be taught. I work with a lot of social workers and case managers, particularly with patients who have financial difficulties. And of course, I work with the outpatient clinic, handing off any important information from the inpatient side to the outpatient setting. For patients who I see in the hospital, we do a lot of survival skill education, helping them get ready for discharge. I'll also help follow up with the patient over the phone, or if they come to the clinic, I'll see the patient in the clinic. Since we implemented the pharmacy transition of care program, we've seen improvements in readmissions to the hospital, medication adherence, first fill compliance, as well as A1C change from inpatient to outpatient.
Between the new technology and the new medications available, there has really been a revolution in how we manage diabetes. And my vision for the future of diabetes care at Northwell includes incorporating technology into inpatient diabetes management and in the transition of care from inpatient back to community. I am extremely optimistic that we are going to see these new technologies and medications improve outcomes for people with diabetes.
Thanks for watching, but now an important disclaimer. The content of this video is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Viewers should not disregard or delay in obtaining medical advice for any medical condition they may have and should seek the assistance of their healthcare professionals for any such conditions.